Hello, greetings everybody. Welcome to today's Office of Work, Life and UK Elder Programs Lunch and Learn. We have with us a distinguished guest today, Dr. Greg Jicha, who's been with the Sanders Brown Center on Aging for 15 years. He's a professor of neurology and is an expert in the ABCs of dementia, which happens to be the title of our workshop today. A few housekeeping items before we get started. We do have participants on Zoom today, and so they will be asking questions online. So if you happen to ask a question in the audience, we'll probably repeat that so they can hear it online as well. We do have some upcoming events of interest for anybody that is interested in these topics of senior caregiving and elder care. First is our Senior Caregiving Conference that the Office of Work, Life and UK Elder Program is sponsoring, which is on Friday, November the 8th at the Hillary Boone Center. We have a flyer in the back if you're interested, and our registration opens tomorrow. We also, as part of that, have a free resource fair for people who are interested in coming and just speaking with exhibitors and vendors about various services. Dr. Jicha will also be speaking at the 9th Annual Marksbury Symposium on Aging and Dementia, which is Saturday, November the 2nd. And we also have some flyers in the back if you're interested in that. So without taking up too much more time, I'm going to turn the mic over to Dr. Jicha. And if he wants to say a few additional words about himself, he can. Thank you so much. Oh, yes. Oh, and Azetta would ask me to please let you know to silence your phone. So thank you again. Good luck.
Very good. Very good. Can everybody hear me? All right. Fantastic. So today we're going to talk about the ABCs of dementia. Yes, I'm at the Sanders Brown Center on Aging, and many of you who know that facility on campus, at least on campus, it is a research facility. It is laboratories full of scientists that are making discoveries that are bringing us closer towards cures for Alzheimer's disease. I don't have a laboratory there. I'm off campus, off Virginia Avenue, where we actually have the clinic. And the clinic there sees probably close to 2,000 people a year, people that actually have different forms of dementia, different types of memory and thinking problems that really cross the spectrum from very mild memory problems, or even people with no memory problems at all, but who may have risk for diseases like Alzheimer's, all the way up to the severely impaired. We have over 800 people here at the University of Kentucky that currently are taking experimental medicines that range from new vaccines to prevent Alzheimer's disease through medicines to stop plaques, tangles, nerve cell death, and medicines to also help with the symptoms for those that have more advanced disease. So while I am a researcher, and that's the Ph.D. of what I do, most of my time is spent as the MD caring for patients. Whether I care for them in the context of my clinic or in the research clinic is semi-irrelevant. It does have bearing on who pays the bill. At the research center, I pay the bill. At clinic, they pay the bill. And whether or not they have access to some of these experimental medicines, but it's all of us really pulling together clinically and research-wise to create the day when dementia is a thing of the past. So today we're really going to go through the basics of dementia, and I think it's really, really important. This is a slide that I love showing the medical students. It's a slide that was made in 1990. And you know, our current medical school class, there are very few students that actually were born before this slide was made. So I like showing them a slide that's older than they are that actually has relevance and bearing. So this was actually done by epidemiologists in 1990. And what they did was they looked at, you know, what was the population of patients with dementia in the United States? It was 3.8 million. And they said, well, how bad is the problem going to be in the future unless we do something about this? And from what we can see, you know, we're keeping track with these numbers. Almost 6 million people today in the United States with dementia. and that problem is going to grow. And the part of it that's really growing is the population over the age of 85. So nowadays, when I see a 65-year-old in clinic, I'm thinking teenager, barely out of college. It's not until people hit 85 that I start thinking, now you're pushing that, the age limits. And age is one of the greatest risk factors. So this is the population that we're seeing. The overall incidence of dementia, so new cases of dementia per age group, is actually stable and or potentially even decreasing in some Western countries. And that is because we've adopted much healthier lifestyles addressing many of the risks for Alzheimer's disease. We're eating better, we're staying more physically active, we're staying more mentally active. So while the total number of people are growing, because the population is growing, especially the aged population, our individual risks may actually be decreasing for dementia. So that's good news overall. So we're going to talk about the disease course today, really as a course. Everybody knows, it's rare unless we have a major stroke or something catastrophic occurs overnight. Dementia does not happen in a day. It's a process that occurs on average for most forms of dementia over about a 10-year period. And we see folks progressing from very mild memory symptoms. And on the y-axis here, we have a standard test called the MMSE. It's 0 to 30 points. 30 is a perfect score. 0 isn't doing so well. And we can see over time that as one begins to develop some early cognitive symptoms, there may be a delay, even by several years, before they're brought to see a doctor. This is a period of time where we scratch our head and we say, well, it looks like they're having a little bit of memory problems. Well, maybe it's just age. We go back and forth, not really sure if there's a problem until eventually it becomes quite clear, we have some issues here. We've got to bring it in to see a doctor. And a diagnosis is made typically when that score has dropped to about 20. So we've already lost about a third of our cognitive abilities before we're even diagnosed. Soon afterwards, we can start to see a loss of functional independence. The memory and thinking problems become much more severe, and we're unable to do all the things that we normally used to do in our day in, day out life. There can be behavioral problems, and this can be a major issue, and we'll talk a little bit more about those. Eventually, a patient will progress to the point where full 24 hours a day, 7 days a week care is needed. That can be provided in home, but it's very, very difficult. Even for some of our larger families, trying to pull together, it is a major task. And so frequently, a dementia care facility or nursing home placement is required in the final years of life. All forms of degenerative dementia are universally fatal. Eventually, all patients will die. That's a shocker to some people. I always say, well, I didn't know that Alzheimer's was going to take my life. It will. Most of our folks pass away from a lack of nutrition. They lose the desire to eat. They don't want to eat. They don't want to drink. Maybe infection, being bedbound, blood clots, the other things that people get when they don't move around. But we cannot actually keep someone alive. Eventually, the disease spreads to the brainstem, and their heart will just shut down and no longer beat. So these are fatal problems in the elderly. And for those with the disease, sometimes families and even myself may feel that it's a blessing when they pass away in their sleep unexpectedly before they hit those later stages of disease. So a memory and thinking problem is an issue, but for me, I really couldn't care less. All of us can be forgetful. Sometimes I'm an absent-minded professor, and I like that aspect of myself. This is the real meat and potatoes. Now we have the MMSE score. Gotcha. Now we have the MMSE score on the x-axis here, from 25 down to 0. And what we see up top are the issues that one has in terms of their daily life. First, trouble keeping appointments. I'm very proud of myself today. That was a task. the ability to use the telephone. We're not talking these newfangled cell phones. I always have to get my kids to show me, how does this one work when I get a new one. But obtaining a meal or a snack, traveling alone can be some of the very early signs that there's an issue. We have folks that frequently can't figure out how to use their home appliances, and so it's quite often that we will have the family disconnect the stove before they blow up the house or burn it down. Finding belongings, dressing, grooming, and eventually walking and eating are lost as well. So it's really this functional decline that robs us of the quality of life that we would like to have as we age. And so, in my opinion, this is the biggest problem. So we talk about dementia, and the number one question that we get from folks in the community is, well, you know, what's the difference between dementia and Alzheimer's disease? And this is great. I even have patients that come in and see me and they say, you know, I don't have Alzheimer's disease. My doctor says I have dementia. And I always just smile and say, well, that's wonderful. That's good for you. If you're more comfortable with the D word than the A word, whatever co-ops and helps us to help people maintain their function. So dementia really is this umbrella term, and all it says is there is some problem with your brain that's causing memory and thinking issues. It does not apply an etiology or a diagnosis. So in essence, the diagnosis of dementia is like the diagnosis of chest pain, right? And if you went to the doctor and said, doctor, I have chest pain, and your doctor said, well, you're right, you have chest pain, and gave you a bill and sent you on your way, you'd walk out of there pretty darn disappointed, right? You'd be saying, you know, well, I know I have chest pain. I'm the one that told you. Why are you billing me? I should bill you. But what you really want to know is why. Sorry about that. Momentary pause. So what you really want to know is, why am I having the memory and thinking problem? Because only by knowing why can we actually do something about it in an intelligent fashion. So really, when you bring somebody to the doctor, you really should demand, what's the diagnosis? That's important. Certainly, when we look at risk factors for dementia, age is the #1 risk factor, and this just skyrockets. Once we're over the age of 65, the risk for Alzheimer's disease doubles every year, so it increases in an exponential sort of way. Now, it's kind of interesting. There are many different forms of dementia, and we're going to talk about those. Alzheimer's actually starts to decrease in frequency once you pass the age of about 90. And that's amazing. You could actually outlive Alzheimer's disease. The problem with that, though, is that you've got everything else coming to get you. And some of the biggies here are two, vascular dementia, what we used to call hardening of the arteries in Kentucky. This is a really big problem, one that we're working on in great earnest here. And the other is a disease that was really just described in a publication this April, and actually it is responsible for about 1 out of every 5 cases. 20% of people told that they have Alzheimer's disease after a workup actually have a different disease. It's called late. And it was named late, which stands for limbic associated TDP-43 encephalopathy, always a mouthful. As I always tell my patients, we use big words like that so that we can bill you more and you can't complain. But late, the acronym, describes just that. It's a dementia that occurs in late life, and it's different than Alzheimer's, probably requires a different treatment. As a matter of fact, not only was the consensus conference put on by the University of Kentucky with funding from the National Institutes on Aging, the lead author of that, Dr. Pete Nelson, our own neuropathologist here, Dr. Nelson and I actually have an NIH grant, several $million grant, to test the first medicine for late disease in the aging population. Hopefully that will start in December. So age is certainly a consideration. So when we look at that umbrella term and we say causes of dementia, well, is it just Alzheimer's and vascular dementia, hardening of the arteries? No, you know, there are many different causes. Neurodegenerative conditions on the left, And there's the big four that we're going to kind of focus on today: Alzheimer's, frontotemporal dementia, dementia with Lewy bodies, and vascular dementia. But I see many people in clinic who have had HIV for 20, 30 years, and they're starting to develop dementia as a result of that. Normal pressure hydrocephalus, too much fluid on the brain, Parkinson's, other Parkinsonian disorders. But very, very important is on the box to the right, and that is medical causes of dementia. And we search for these, and so it's critical when somebody comes down with a memory and thinking problem that we actually stop, take a breath, and say, is this potentially something fixable? Or we toss a packet of Aricept or Donepezil at somebody, we want to know that they don't have these other conditions. So frequently we will see folks who are on a number of medicines that can impair memory. We actually have a NIH-funded clinical trial currently called the INCREASE study, where instead of giving people experimental medicines, we're looking at their medication list with the College of Pharmacy, and we're taking them off medicines that could impair their memory and thinking. And we're finding that some folks we can restore to normal memory if we get them off all their medications. And these are maybe good medications. They may have been great medications when they were in their 50s, but when you're in your 70s and 80s, you're a little more sensitive. Brain's more sensitive, your liver and kidneys don't work as well. This can be a big problem. We look at thyroid problems, endocrinopathy. So thyroid is a big culprit for reversible causes of memory and thinking. We look at vitamin deficiencies, vitamin B12, folate deficiencies in particular, but there can be others. Sometimes chronic infections, brucellosis, which comes from cows, can mimic Alzheimer's disease. Sometimes I do find folks with brain tumors, other lesions, multiple sclerosis, sometimes memory loss related to untreated or unrecognized depression or anxiety. We'll talk a little bit more about that in a bit. There are some common behaviors in dementia, and these are things that we should all recognize in ourselves and in others as warning signs. So short-term memory loss, repetition, saying the same thing over and over again. This is important, asking the same question. One of the earliest signs actually is apathy, a lack of initiative. I no longer want to do all the things that I used to do. We can see emotional changes. We'll talk a little bit more about that. Agitation, anxiety, a resistance to cares. Many folks believe that they're fine. As a matter of fact, I had to sit down with somebody on Friday who I've been following for about 12 years now, a very young woman. She's in her early 60s now. I've been following her since her early 50s. She has both parents with Alzheimer's disease. She carries all the genetic risks and actually was positive in her spinal fluid and brain imaging 12 years ago. It's finally caught up to her, and I had to have the talk. You can't stay at home alone anymore. You need a companion, and you definitely cannot drive. And her argument was, I'm perfectly fine. And, short-term memory problem is great for that purpose. I think it's something the good Lord didn't spare us. Somebody that can't see their memory problem is not tortured by it the way that those around them are. And that can be helpful. Wandering, pacing, wanting to go home. There's a phenomenon called the capgras delusion. And that is, well, this looks like my home, but it's not my home. I want to go home. You look like my spouse, but you're not. What'd you do with the real one? Like invasion of the body snatchers, very, very common. Shadowing, that's when somebody just follows you around, and this can be a problem as the disease progresses. You can't go to the bathroom alone because your loved one wants to join you in there. And we can see hallucinations, changes in sleep patterns, rummaging and hoarding. Two of my favorite patients, both since passed away, but the family thought there were some mild memory problems, but they didn't think much of it until they came over for Thanksgiving dinner. And one of them had to run out to the garage to get something that was out there. When they opened the garage door, it was stacked to the roof. Turns out both parents were simultaneously developing dementia together. And the mother loved to collect teddy bears. And so she was on eBay buying every teddy bear she could find. Well, her husband didn't want to miss the action. He liked Matchbox cars. And so they literally spent their entire retirement savings on teddy bears and Matchbox cars. It took the family, after we were able to identify this is a dementia, this hoarding behavior, it took them about 7 years to sell back on eBay all of those teddy bears and Matchbox cars. They eventually did it, I believe, though. So we may see a variety of these behaviors, and they're really, really important. These are what we call behavioral and psychiatric symptoms of dementia. And this is just a great graph. On the x-axis, it has months before and after the diagnosis, and the red bar is 0. That's when we say, yes, indeed, there is a problem. This is Alzheimer's or Lewy body disease or whatever. And so we have time before that and time after that. And on the y-axis is the frequency, the percentage of patients that may experience these symptoms. And what we can see is that 3 years before a diagnosis is even made, we see social withdrawal, people pulling back from their activities. 2 years before a diagnosis is made, 50% of people can be experiencing depression. Depression as a sign of the impending memory loss. Disruption in sleep patterns, anxiety, paranoia, 1.5 years before a diagnosis is even made. And within a year after, we can see over 80% of people experiencing agitation, aggression, hallucinations. These are major issues. And why is behavior a problem? You know, we always say this, and we work with patients and families, and the families frequently are like, I don't know why they are doing this to me. And the patient isn't really trying to do it. It is all part of involvement of all these degenerative diseases tend to attack the oldest areas evolutionarily, the oldest areas of the brain. The limbic system, this is where our emotions exist. And it's quite interesting, you know, I think, I always used to think, that Mr. Spock was the epitome of good memory from Star Trek, logical, Vulcan kind of guy. But it turns out that memory is not that way. Memory is actually emotional. And so it's part of this limbic circuitry, and that's what makes memory work for us. We remember the things that are emotionally important, good and bad. We're going to remember those. So it's this limbic system, these what we call archicortical areas of the brain, older, ancient brain, that manage both emotions as well as memory. And these diseases run rampant in these areas very, very early on. So when someone with dementia is not behaving appropriately, they're not doing it on purpose. They can't behave appropriately. They may have been able to manage their emotions in the past and never suffered from depression, but when the disease takes hold, they no longer can manage this. And so we need to understand that that's the case. So when one comes in and we start thinking about, well, is there a problem here? We know that there's kind of this artificial, are you normal or do you have dementia? And it's just not that way. It's a slow and slippery slope. And so in the middle, we've kind of falsely created a stepping stone, what we call mild cognitive impairment. And one moves from normal to mild cognitive impairment with a decline in cognitive abilities, memory and thinking. But at this stage, people are able to compensate, right, with sticky notes, right? I am a major contributor to Post-it notes. I should have bought stock. I once cared for the person that invented Post-it notes, by the way. He sold the concept and idea for $200,000. Can you believe that? He tortured himself. I also once took care of the man who invented the little metal ring on the end of a pencil that holds the eraser on it. And he made like 1/10,000th of a penny for every pencil made. He was a billionaire. Billionaire. Amazing. So one moves from mild cognitive impairment to dementia, yes, because their cognition is getting worse, but it's the fact that they're beginning to develop a decline in function. So very, very important. And we work on this with our early recognition of memory problems today by recognizing mild cognitive impairment. We know that the earlier we get somebody started on medicines or identify a reason for their memory problem, the better they will do over the long run. So we really try to focus on this stage. We don't like seeing somebody coming in for their first evaluation who doesn't know their own birthday and is already in dependence. That's no way to go. We like to catch people early. And so we look at mild cognitive impairment and we ask several questions. Is there a cognitive complaint, right? So we want to know that there's a cognitive complaint from the person or one of their family members or friends, because we want to know that this is a change. So one of the groups of folks that we study that are at very high risk for Alzheimer's are adult Down syndrome patients. We have another NIH grant where we're following folks with Down syndrome. They all universally come down with Alzheimer's disease, at least in their brain, by the time they're age 40. Many of them much younger. We see Alzheimer's in the 20s in adult Down syndrome patients. And they're impaired at baseline. So it's hard to know when we get somebody in with Down syndrome. Well, they can't do our memory and thinking test, but could they ever have done it? We have to ask that question. Is this a change from their past performance? If it is, we test them. And if we find that there is evidence for memory and thinking decline, we classify them as mild cognitive impairment. We then break them down by, is memory involved or not? We call it amnestic or non-amnestic, and then we ask the question, is it just memory or is it something else? And come up with single and multiple domains. The purpose is to put those forms of MCI into this type of a grid and say, all right, if we've got memory being affected early, maybe this is Alzheimer's disease. If we don't have memory, but it's behavior, maybe it's frontotemporal dementia or Lewy body disease. And so it's all to work on figuring out at the end of the day, what exactly is the medical cause? This isn't just chest pain, right? There's a problem with the heart. What's the problem? And for dementia, there's a problem with the brain. It's not just dementia or mild cognitive impairment. What is it? So I always say, funding right now is extremely good in the field of Alzheimer's disease. We really have marshaled together as a nation to tackle this. We currently have what's called NAPA, the National Alzheimer Project Act, with a goal of a cure, something that will slow or stop the disease by 2025. Now, that's only a little over 5 years away. So many of the medicines we're testing today may well be those cures of tomorrow. And one of the reasons why the nation really has rallied is on the basis of this kind of data. So this big green circle is the population of the United States, and in yellow, this little slice of pie here, is the 39 million people over the age of 65. And when we blow up that little slice of pie, we know that 13% of the US population over the age of 65 has dementia. That's over 5 million. These figures are from 2012. The situation has gotten much worse. We're at about 6 million currently, but this is a big problem. But if we start looking at the people with mild cognitive impairment that are also on that slippery slope, we can start to see that the problem is even bigger. And it's really about 1 out of every 3 people over the age of 65 that increases with age. By the time you reach your 80s, 1 out of every 2 has some form of dementia, many of them Alzheimer's disease. So I frequently do tell the medical students as well, if your grandparents come over for Thanksgiving and they're in their 80s, and both of them are still alive, you can bank that one of them has dementia, whether or not you pick up on it. So be on the lookout, try to identify that. So with this many folks impaired in that aging population, it makes the golden years look like it's not really pure gold, right? It's like Mexican jewelry or something of that nature. So we need to bring back those golden years. So there's a few things that we can do, and each of you might think about this. There was a tool made several years ago called the AD8. It's 8 questions that have high predictive value. If somebody If you say yes to 2 of these questions when thinking about yourself or thinking about somebody else, there's a 95% chance that they have mild cognitive impairment or dementia. So are there problems with judgment, making decisions, bad financial decisions, problems with thinking? Now, that doesn't hold true for someone like myself who has never made good financial decisions, all right? As a matter of fact, I can't even balance a checkbook. The last time I always say I balanced my checkbook was when I was a medical student, and I went to the ATM machine and stuck my card in, and it said insufficient funds. Then I'd always say, yes, balanced again. Right at 0, right where I know I am. Less interest, getting back to that, apathy, repeating, right? Trouble learning how to use tools, appliances, or gadgets. Forget the correct month or year. I like to give people the benefit of the doubt when it comes to day of the week or the date. When I'm retired, I don't want to know either of those. But somebody who comes in, like my young lady last Friday, who told me she thought it was February when it was 95 degrees outside, has a real problem. Clearly. So trouble handling complicated financial affairs, that is if it's a change from past performance, remembering appointments, daily problems with thinking or memory. So this is quite easy to just simply stop and ask those questions and say, is there a potential problem here? So now I also look for, and this is something, and this is kind of my practice from doing this over the last several decades. There are certain symptoms that are so common with different forms of dementia that we've got to stop and address those. And I address these with virtually every person that comes into the clinic. Is there depression or anxiety? They may be the cause. Sometimes I see somebody who comes in who's age 40 and their child died of a car accident or whatever, and they're severely depressed, and that's where their memory problem's coming from. But as I said before, because of the limbic system, this may be a part of a disease like Alzheimer's that also needs to be fixed. I ask about behavior, personality change, obsessions, compulsions, inappropriate behaviors. We see these frequently in frontotemporal dementia. We'll talk a little bit more about that. I ask about hallucinations, delusions, paranoia. We frequently can see these very early on in Lewy body disease, but we will see these in Alzheimer's as it progresses as well. I ask about sleep, obstructive sleep apnea, insomnia, what we call dream enactment behavior, violent dreams that people act out kicking and punching, circadian rhythm flip-flopping, the sleep-wake cycle. Again, these may need treatment. And of course, physical motor symptoms. Is there any Parkinsonism? Are they shuffling or tremoring? Anything of that nature? This is a good panel of the things that we look at in association with memory or thinking problems. And of course, when someone comes to a doctor, we like using these cute little testing forms. This is a great one. Everybody loves this. The Montreal Cognitive Assessment has got little pictures of animals. And the testing, you know, for the most part is relatively straightforward. Can you connect 1 to A and A to 2, 2 to B, and B to 3, 3 to C, and 4 to D? Straightforward. Can you draw a cube? Can you draw a clock? Can you name these 3 animals? Can you remember a few words and a variety of other tasks as well? We also look at a physical exam and we check people out. You know, how's the heart? You know, is it an abnormal rhythm? How are the carotids? Is it potentially due to a stroke? Anything else on board? We screen for a variety of different findings. And some of the findings that I find fascinating, anyway, are called frontal release signs, primitive reflexes. These are actually reflexes that we're all born with. As babies, we have all of these because the brain is immature, and we slowly lose these over the successive years of life, but later in life, if the brain is injured, they come back again. So we do something called the glabellar tap, where we tap on the forehead, and someone with dementia will blink, and they'll blink every time you hit them. Somebody with a mature and normal brain might blink once or twice, but then they determine, hey, you're not going to stick your finger in my eye. I can stop blinking now. And we suppress the reflex. A snout is something that's important for babies learning how to breastfeed. You touch the lips and they just pucker up for us. I will start to see these behaviors come back. Rooting reflexes, touch the corner of the mouth and the mouth orients to that side, again, related to breastfeeding. A fascinating one, we scratch the palms of somebody's hand, and if you scratch real quickly, the muscle in their chin, their mentalis muscle, contracts and twitches. It's a fascinating reflex. And then grasp reflexes as well. Beyond that, we send patients for brain imaging, and a lot of this is research that's been done over the years. So here you can see a normal brain, and what's highlighted in red here are the memory areas of the brain, what we call the hippocampus. The horse, it's shaped like a horse's head, a seahorse. And in a young normal, they're big and plump and juicy. All of our brains shrink as we age to some degree. This is somebody with normal memory, 75 years old, still doing pretty well with their hippocampus. We see another 75-year-old with mild memory problems, mild cognitive impairment, but not full-blown dementia, shrunk a little bit more, and Alzheimer's. Boom, huge shrinkage there. That's the memory problem. And we can look at that brain imaging and we can determine not only are you healthy and normal, or do you show this shrinkage of the memory circuits. Is it a tumor? Is there too much spinal fluid? Is there a lot of vascular, this white change from strokes and hardening of the arteries, or different patterns of shrinkage of the brain that could identify different diseases? We sometimes can send people on for PET scans. This is FDG PET. It's sugar PET. It's radioactive sugar injected in your vein, and our normal brain just lights up. It's really amazing. Does anybody know how much the brain weighs? Anyone want to guess?
20 pounds.
No, it's about 2.5 pounds. And so in terms of your entire body, you've got this little organ, 2.5 pounds. It uses 30% of the glucose circulating in your blood every minute. Can you believe that? So any of you who brought your lunch today and ate it, a third of that lunch is going to that little hungry 2.5 pound organ upstairs. So the brain is chewing up that sugar. But in diseases like Alzheimer's, it can no longer use the sugar. It's powering down. We also have developed the ability to do amyloid PET scans to actually inject a radioactive tracer that will bind to Alzheimer plaques in the brain. And here we can see an Alzheimer patient with their brain lit up. We're doing these routinely here at the University of Kentucky, mostly for research purposes. It is FDA approved. Most insurance won't pay for it. It costs about $5,000–6,000 bucks. But we do a lot of this in research. One of the reasons why we do it in research is because of these findings. This is somebody who's normal, who has no tracer uptake, just some artifact. And then here are two normals who are already building up amyloid plaques in their brain. We know that that occurs about 10 to 20 years before the first memory problem appears. And so when we look at Alzheimer's coming on in the 70s or 80s, this is all beginning actually in our 50s and early 60s for many folks, much younger for many others. As a matter of fact, the adult Down syndrome folks I was talking about, we have evidence for Alzheimer plaques in babies with Down syndrome as young as 6 months of age, already laying down Alzheimer plaques. We can also check spinal fluid. This is my back. I donated my spinal fluid to the center. I drew somebody's spinal fluid this morning. I have to draw spinal fluid again this afternoon. We can measure the spinal fluid for Alzheimer-type proteins. This has been incredibly helpful for us. And then again, we're looking for reversible causes in almost everybody. We do have to worry sometimes about dementia versus delirium. And so Dementia really is something that occurs chronically over time. We will see people in the hospital who start hallucinating or becoming very agitated. Does not mean that they have dementia if they become delirious in the hospital. So if any of you come down with the flu, you don't get your UK flu shot this year, and you wind up with it with a fever of 106, you might hallucinate too and not be thinking real well. We certainly wouldn't call you dementia in the setting of an acute illness. So this is how we diagnose somebody. They come in, some impetus for consult. We do our neurologic bedside evaluation. We do a medical workup looking for these things: depression, folate, B12, thyroid, picture of the brain. From there, we define the type of dementia, sometimes using biomarkers. And once we've defined the disease, we begin to treat it as well. I'm not going to talk about that. I'm going to move forward because we're running out of time, and really just touch base again on the big four. We have Alzheimer's disease. This is what we know about it. We know that there are plaques in the brain that exist outside the nerve cells, and within the brain, within the nerve cells, neurofibrillary tangles. We know that having a big stroke, as we see here, is not real good for your memory and thinking. This is somebody with vascular dementia. Lewy bodies, and Lewy actually was a pathologist, like Alzheimer's himself. All these people wanted diseases named after them. I also tell the medical students, try never to have a disease named after you. Have a cure named after you, right? Like the Salk vaccine, right? We call it polio, but the vaccine is Salk, much better. So Lewy bodies are a different pathology in the brain, and some forms of frontotemporal dementia that affect the behavioral areas of the brain, this is Pick's disease, have yet different pathologic inclusions. So these are different diseases intrinsically. And they manifest differently. So with Alzheimer's, we're looking at progressive worsening of memory and cognitive functions, functional impairment, absence of other disorders, and there's no other form of dementia. For vascular dementia, we're looking to see, does this person have high blood pressure, diabetes, high cholesterol? Is there signs of a stroke on their examination or on their brain imaging? And is there a relationship of that stroke or other TIA to the memory and thinking problem? Dementia with Lewy bodies is a cousin of Parkinson's disease. We will see mild Parkinsonism, mild shuffling, very early hallucinations. So I have somebody I saw last week who has a imaginary cat that lives with them in the house, and they see the cat all the time. They know that the cat's not real, but they see it everywhere in the house. Fluctuations in memory and thinking, depression, sleep disturbance, violent dreams, and then frontotemporal dementia is often behavioral problems, loss of interpersonal skills, inappropriate behaviors, or language involvement. And so one of my jobs as a clinician is to tease this out. When people come in with very early problems, I can see, if we look at cognition, language, psychiatric symptoms, behavior, motor, all four of these types of dementia look very, very different. That's what my job is. But as the disease progresses to the mild stage, we start seeing problems emerging across the board. And as we hit the moderate stages of disease, they start looking more similar. And at the end stage of disease, all of these dementias end up in exactly the same place with widespread problems across all domains. So only by finding somebody early on in the disease course can we accurately identify what's going on and then potentially treat. So let's talk about treatment and have a very straightforward approach. We don't yet have any of those cures that we're looking for to market. So currently, all of our medicines treat symptoms. So what we need to do when somebody's brought in to see us is we need to talk with the patient and the family and say, what's the big issue here? Is it the memory that's the major problem? If so, we'll try these medicines. Is it behavior that's a problem? We might try these. Is it hallucinations or other psychiatric conditions? We might try these. Is it motor function, like in some of the Parkinson's disorders? And we might try those medications. And then every few months when we bring the patient back, we reassess. All right, what's our current problem? Trying to put out the fires. So we do have some medicines that we use. Medicines that augment cholinergic function. I'm not going to talk about this, but I will show you some of the pictures. We have what are called cholinesterase inhibitors. These help the brain keep a very important chemical around, acetylcholine. It's important for memory and thinking. And what we know is an Alzheimer or dementia patient is on this declining slope over time. This is a 2-year period. Their memory and thinking is declining. If we start them on one of these medicines, we might see a little bump, usually not much, but we stabilize them for about 6 months or so. And then we will see the decline. It's not a cure. The disease progresses, but they're always doing better on the medicine than they would have otherwise. We have other medicines called memantine, and memantine is very, very important for helping nerve signals, as you can see in red here, really rise as we begin to develop Alzheimer's. The background noise from injured nerve cells is so high, we can't see that signal. Oh, that's shown over here. And with this medicine, we can knock that noise down. We can again see the signal and make memories. And again, graphs showing the same thing. If you're on the placebo, you're going to decline much, much faster than if you're on these medicines. So we'll look back at this. This is a memory and thinking test score, 30 to 0. And this is time. And what we know is that this is the curve. If we do nothing, this is what's going to happen. If we place somebody on a cholinesterase inhibitor, we start to see this curve. So again, some stabilization, then continued decline, but always above. And if we start both memory medicines, we see a curve that looks like this solid bar. Nonetheless, at the end of 10 years, we all wind up in the same place. It doesn't stop the disease. But at the end of the day, we could ask that fundamental question, is it worth treating? Well, do you want to be here, here, or here? Here, 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 here. Every step of the way, I would want my loved one to be in the green circles, not in the red circles. So that's kind of what we're doing as we treat folks. I'm going to stop there. There's just so much more that I could talk about, but I want to make sure that there are time at least for a few questions before we all have to get back to work. That would be important.
Will we be able to get these slides? That would be, some of the earlier information is really helpful for me. When you talked about the behaviors, I didn't see anything about starting a sentence and not being able to finish them.
So that's what so the question, two questions. One is, can we get the slides? I am completely delighted for you all to have the slides. So I don't know if Elder Care is going to make them available to you. If not, email me and I'm happy to send them to
Great,
you.
thank you.
We're actually making an archive, one of our big pushes right now, because a lot of what we do is kind of almost done in secret, and it's not really being done in secret. It's just that we haven't had ways. And we've actually begun posting, and we're developing our website for Sanders Brown currently, have all of our presentations put on the website, and we have a videographer who's coming around to most of our community presentations and videographing them. We're making a huge YouTube library, so you'll be able to get on there. Our biggest hit, we have about 8 or 9 posted so far. The biggest hit is so far has been, is CBD oil good for your Alzheimer's disease? Boy, everybody loves that question. The second question was on the slides of behavior. There was not a comment on starting a sentence and being unable to finish it. And that's because I simply, I mean, really, it would fill fill a book to list all the symptoms.
Uh-huh.
That's something we call sentence blocking. It can partially occur with age. So with age, what is common is a slowness of recall. Now, who's that actress in that movie? It doesn't come to you, doesn't come to you. And then about an hour later, when you're driving home from work, you know, you're like, oh, that's who it was. And it pops into your head. That's more normal memory from. We see frequent difficulties with losing track in the middle of conversations as to what the entire conversation was even about. That can be an early marker of Alzheimer's as well. An inability to come up with the word, what we call dysnomia, and it never comes back, right? So I always say that's why one of my favorite phrases is senior moment. Why? Because it diffuses that awkward moment when you run into somebody and you know you should know their name. It doesn't pop into your head. You say, excuse me, senior moment. I'm drawing a blank on your name. Oh, that's right. You can move on, you know, and save face in that situation. It can be very helpful. Do we have time for?
Yes, and I have a Zoom question as well.
All right, so we'll go here first, then we'll move to Zoom.
You mentioned earlier that oftentimes the patient does not realize that they have a problem. Would you have any suggestions? I have a family member who's going through this, and we're trying to figure out a way to get him to the doctor.
Yeah.
So won't go.
That's a, you know, so the question is, because people frequently lack insight to having a problem, they'll refuse to come in for an evaluation. They think that they're perfectly fine. And we deal with this on a regular basis. It's a difficult sort of thing. We usually recommend is that we present it as a well health checkup kind of thing. And so we do this all the time under pretense. We know at the center, we'll already know in advance from talking with the family, uh-oh, there's a major problem here, but we bring them in as a healthy normal just to evaluate. And then sometimes we give them a medicine to try to keep their brain from developing a problem in the future. We don't tell them, you know, because somebody who can't see their illness does not need to know. But we do have to be able to get them care. And so we practice frequently if they lack, it's only for people that lack capacity. We have to be straightforward with everybody who has capacity. We can't go behind their back. But if they have a significant memory problem and lack insight into their disease, that is a lack of capacity where we can immediately move through Kentucky healthcare decision statutes to the legally authorized representative to address these issues. And then we practice with the patient what we call compassionate deception. And that is we tell them whatever we need to tell them to be able to help them and to keep them as healthy and happy as they can be. So sometimes it's like a little white lie, a little fib to try to get people the help that they need. Really, really important. We have to be tricky. Sometimes it's difficult. Or you can do it with brute force, right? We see that sometimes too. So we have one more question.
Yes. So when talking about sugar in the brain, is that why AD patients crave sweets?
So this is a great question, why AD patients crave sweets. So let me just say, you know, that there's a natural phenomenon. We have different taste buds for different tastes. So we have taste buds that only taste sour. We have some that only taste sweet. We have some that only taste bitter. And it turns out that as we age, we lose our taste buds. And the ones that are most resistant to aging are the sweet taste buds. So all of us, we studied this a few years ago. We have many of our folks that are normal fill out what we call a lifestyle survey, where we ask them about many different aspects of their life, from their physical exercise, their cognitive exercise, their religion, spirituality, church practices, their many other questions. And one of them is a food frequency questionnaire. So we ask everybody about what do they eat. We were able to go through this with one of our students and derive grams of refined sugar consumed per day. And we're able to quite clearly see that all of us are developing a sweet tooth as we age. So that really raised two concerns. The Number one, it extends to Alzheimer's disease, and that's because Alzheimer patients become much more emotional and instinctual. You know, we can talk ourselves out of it. No, you know, yes, I'm really craving those donuts these days, but that's enough, you know. I can't do it. As a matter of fact, I had one gentleman with Alzheimer's that came into the center. He was supposed to be fasting for a blood draw, and we drew his blood, and his blood sugar was 650. He said, "Are you fasting?" He said, "Well, I had a donut." And then we said, "How many?" He said, "The whole box."
Oh.
Ate a dozen donuts and came in. But the good news now is we looked at our healthy elderly folks, and we looked at their refined sugar intake, and that's because we know for school-age children, if they consume high quantities of sugar, they do worse in school. So the question really was, are our own bodies, our own taste buds sabotaging our brain as we age? And what we found in the aging population was absolutely no relationship to memory and thinking test performance and the amount of refined sugar that you ate. So I presented that at an international conference with a poster title that said, "Go ahead, have that other donut." So just don't make your blood sugar 650. We will see that tendency for sweet tooths just naturally as we age. But again, the ability to resist eating that whole box of donuts is something that can be lost in a patient with dementia. So, well, that was fantastic. We probably all have to get back to work. I am delighted to that all of you came today to talk about this. I'm happy to come back at any time in the future for any topics. I really work in so many different areas of aging and helping us to maintain our cognitive and functional abilities that I'm just delighted to always share anything that I know with anybody out there.